Hey everyone, and thank you for joining us on the Pre-Hospital Paradigm podcast. I'm John Hill. I'll be your host this evening. To my right, I've got the fantastic Caleb Ferroni, and we've got two special guests this evening. We've got Leisha Starkey and Bethany Roebuck from Thrive for Change. Thanks for joining us this evening. We are here at Highland Heights Fire Department, who's graciously accepted us to talk about harm reduction this evening. So I'd like to thank them for having us here in their firehouse. If Chief wants to say a few words.
Sure. Thanks all. Thank you guys for being here. Again, welcome to the City of Highland Heights Fire Department. We were established in 1939. We currently have 21 sworn full-time staff with 4 part-time paramedics as well. As you see in front of us here is a shift. Each shift is made up of a lieutenant and 5 paramedics. I'll apologize in advance if the tones go off while we're talking, but thank you again for coming out tonight and appreciate you guys being here and what you do.
Thanks, Chief. Thanks for having us.
As a token of our appreciation.
Thank you. Appreciate it.
As always, I would also like to thank you guys as well as FirstNet and Cradlepoint for allowing us to use their equipment and have this go out over the FirstNet network to provide our streaming services here. Anyone that's watching this, we have a deal with them where you can use that QR code or go to prehospitalparadigm.com/FirstNet and get the Century Firefighter discount deal that we all have here, if you don't already have FirstNet, of course. So I think that takes us to everything that I needed to hit at the top of the show. I'm going to reset our call counter to 1 just in case you guys do get called out. So, Leisha and Beth, do you guys want to tell us a little bit about yourselves and Thrive for Change?
Of course. So, good evening, everybody. I'm Bethany Roebuck. I'm the executive director and one of the co-founders of Thrive for Change. We're a nonprofit based out of Cleveland, and we provide harm reduction services. We do a lot of street outreach in overdose hotspot neighborhoods, education, advocacy, have a mail order program where anyone in Ohio can access free Narcan, testing strips. And so that's a big portion of what we do is the Narcan distribution, but that's just a piece. There's a lot of other services that are encompassed in harm reduction. And I've got Leisha, or Leish, here with me. Do you want to introduce yourself?
Hi, Leisha Starkey. Leish. I'm the Community Engagement Response Coordinator with Thrive for Change. I'm also a volunteer coordinator. So a lot of what I do is working with the community to provide, we have an overdose response bulletin, so providing information to the community, news articles, trends, education, resources, things like that, but also reaching out to first responders and trying to provide harm reduction and stigma education as well.
All right, so let's start off with the easy stuff. We said harm reduction. I've said it a bunch of times. You guys have said it a bunch of times. Mm-hmm. Harm reduction's a lot of things.
Yeah.
What is harm reduction?
So we all use harm reduction in our everyday lives, and as people working in public safety use harm reduction a lot too. At the basic level, it's risk reduction. You can think of things in our everyday lives like wearing a seatbelt, wearing a helmet. When you engage in an activity that we know comes with risks, there's steps that we take to reduce those risks. It doesn't always mean we don't engage in those activities. It just means we take those steps to reduce risk. So when it applies to drug use, harm reduction can be things like not using alone, because we know that if people use alone, we're more likely to lose them from an overdose. And it could be other things like testing drugs for fentanyl. So there's a lot of things along the way, but all in all, harm reduction is an approach to drug use in our communities that meets people where they're at. It accepts that drugs are a part of this world, And as much as we've tried to stomp them out over the last 50 years, they are still here and are probably here to stay. So how do we keep people safe? How do we help folks make positive changes without judgment and offer support?
I got to tell you, it was really amazing to me. I was kind of behind the scenes when this episode was recorded and listening to what was said. Like, we've done mental health episodes before, and this was a whole different animal, and it really opened eyes to some of the stigma and that you've talked about, and just like the hierarchy we were talking about before, just even between like people who use that, how some are considered dirty and not. It was just really eye-opening, and it's something that nobody really thinks about. And it was really neat to sit back and hear that.
Yeah,
So.
Absolutely. I know, like, Leisha, you've been in harm reduction work for, what is it, like a year and a half now?
Yeah.
I didn't know if you wanted to talk any about your experience, like when you first were more like introduced to it.
It was very eye-opening. I didn't realize how large stigma was. So I guess personally for myself, I get really excited when I'm able to go out to the events or even just to street outreach. Like for myself, I feel like providing one Narcan to the community is it's better than nothing. You know what I mean? And like, for example, last Saturday we had Akron Pride, and there are so many people that came up to us, and I'm just like, would you like some Narcan? No, I don't know anybody that uses drugs. And one of the first things we say is like, well, you really don't know. Or you say, you never know when you might be able to save someone's life. And something as simple as that really can make somebody just think and say, you know what, I'll take one, I'll take two. And just something so small can really just have an impact. Akron Pride they were estimated to have up to 14,000 people. And everybody said, well, I have it at home, I have it in my car. I said, well, that's great, but what if something happens to someone right next to you? What does that do? So it's just been really eye-opening and really exciting to see the way people have been able to change their minds a little bit and open up their perspectives.
Yeah, just for us being present in different spaces. Yeah.
And it doesn't matter where you're at, like you said. I mean, we had talked a little bit before this, even, in eastern Geauga County we could have problems, and it doesn't have to be inner city.
Right.
So it just doesn't matter. And what does it hurt to carry it?
Nothing. Right.
Yeah, I was at an event where there was a lot of EMTs, and they were even helping me like give it to people. They're like, yeah, it's like a fire extinguisher. You hope you never need it.
Absolutely, yeah.
But if you do, you're glad it's there.
Yeah, absolutely.
Well, I think one of the good other things to talk about is, let's say that you come across someone who you think's overdosing. It's okay and safe to give them Narcan.
Yeah.
But
Yeah.
giving them naloxone is not going to cause any harm.
Right.
It's only going to help.
Over the counter, people have used it. Like, it's unfortunate situations, but have used it on pets, on children. Like, it is a safe medication. So.
And it's actually through Thrive for Change, after we recorded that episode, that next morning, just because I went to your website and I signed up and I got Narcan within 5-6 days. And it was just insane to me. Like, this is so cool. So I told my family about it. So you probably had a lot of Ferronis right into Thrive for Change. But the more the better. And I couldn't believe how easy that was. And you guys made it really possible and easy, and that's really cool.
Yeah, I've sent a lot of people to your website. I got my first set of Narcan from you guys through mail order because it was just really easy. I don't have to go anywhere. Don't even have to go to a pharmacy. It just comes directly to me. So if anyone out there needs, go to Thrive for Change and it'll send it right direct to your door. And you guys send out fentanyl test strips. And what else do you guys send out via mail?
So we send a lot of things through the mail. So we actually have two separate mail order programs. We have the one that's mainly just like the naloxone, fentanyl test strips, and then we send safe injection kits that don't include syringes, but like other things to help prevent like disease spread or infection, safer snorting kits, and safe sex kits. So that's what we send through like that section of our program. And then we actually launched over the last year, it's still like kind of getting off the ground fully, the first mail-based syringe service program in Ohio. There's programs like this based out of New York that cover multiple states. There's lots of programs throughout the country like this, but Ohio didn't have a program. And so we worked with the centers, one of our partners, to launch the first program for Ohio, because there's a lot of people in rural areas. Like, we're super lucky in the Cleveland area that we can address things like the spread of HIV and stuff like that by having syringe service programs. But in very rural areas, they either don't have the resources or the stigma is just too high that they can't access those services. So we did launch that program with like very limited funding and support. So we're slowly rolling it out.
Excellent. And what you talked about, what diseases are you trying to prevent the spread of? When we talk about safer use kits, you're talking about moving away from injections and sharing needles to either snorting or smoking the drugs. But what's your overall, from harm prevention standpoint, what diseases are you trying to stop the transmission of?
There's a lot of different ones. So like, I obviously mentioned HIV, hepatitis C. Those are the big ones, and then people can develop like endocarditis and like staph infections, things like that, from reusing or sharing supplies. Even like, we build awareness with our folks who smoke drugs, smoke stimulants, that like sharing pipes and things, if like they have cuts and burns, stuff like that, like things can be spread. So it's a host of things, but like also if people have infections, that leads to a whole bunch of other conditions.
So infectious endocarditis is actually hard for us in the medical community, to the point where if we're drawing blood cultures on someone, we typically get 2 to make sure that we're treating the right thing. We actually typically add a 3rd just to make sure, because sometimes for us in medicine, it's hard for us to catch infective endocarditis. So practice is to actually get a 3rd blood culture in hopes that you can possibly draw it out to see if we can, if we hear a murmur when we're doing our assessments, and then get the echocardiogram and see a vegetation we don't know is that infectious or non-infectious. With having a drug use history, it raises our concern and suspicion for that. But doing the diagnostic of it is sometimes more difficult in those patients.
And a lot of times we think about it in like the moment of like the healthcare costs to that individual and stuff like that. But also that can be a barrier for people when they do, if they do like move forward into some form of recovery. Like if they have all these medical bills and health concerns, then they're less likely to move forward with those decisions. So,
how are you finding to get your information out the most? Is it through your website? Is it through billboards? Is it just word of mouth? I know that you guys had talked about doing like free meals once a week or whatnot, and you're giving out information at that point. But how are you getting it out?
Yeah, well, Leisha, some of our communications. You want to talk about some of the newsletters that you send out, and then I can share too.
Yeah, so we have a typically monthly Thrive for Change newsletter, and then also, again, like the overdose response bulletin. So we have some stakeholders in the community, and we discuss news articles, local, national, just things that are going on. We want to discuss, more importantly, trends in the drug supply. There's just lots of things that are going on that like might have started in California and slowly is creeping its way over here. Just really important to be able to spread the word. Educational things that are coming up. We just so many things educationally we just want to provide to the community. Sometimes they just don't see all the time. Also resources. Always being able to remember that you can reach out to Thrive for Change. We actually have our own page we created. It's our OD Alert Resources page. So it's like an all-encompassing hub of resources. So like if you needed to find, if you needed to go to the centers, if you wanted to have like walk-in medical assisted treatment, you go to the centers. We have all the information there. We have all the locations there, their telephone numbers. We have different partners on there. If people wanted to access Narcan in a different location that's not in Cuyahoga County, we just have like a plethora of things on there. I think I'm missing something, but
no,
yeah.
that's good. Yeah, like I think the more we communicate, we can like establish ourselves as like a resource for providers, but also for people actively at risk. And a lot of the folks that we see in neighborhoods, that's a lot of like word of mouth. And the meals has been a huge thing. So back when we first started,
which I think was genius, by the way.
Yeah. So when we think about stigma, if you have a sign that says come here for free Narcan, there's several things that people go through in their brain before they're maybe like approaching that table. But if you say, hey, we have free groceries or we have a hot meal, people can come up and say, oh, well, I'll take a kit while I'm up here, or I'll take some safer use supplies. So we actually worked with like a food pantry place in Maslin. We were driving like an hour down there to load up a truck and bring it up. We were doing stuff in Akron and Cleveland and all around at that time. And we learned that, yeah, you bring people in with food. And so we aren't able to do it at all of our locations, but at our weekly services on Thursdays, we provide a hot meal for folks, and that always brings people in. It builds social connectedness too, which is like so huge when we're talking about these things. And so that's been a big piece that drives the word of mouth, and just showing that we care about people regardless of where they're at, and having a team of people largely with lived experience also makes a huge difference for like building that trust and connection that then spreads the word of mouth. We also do tons of print materials, flyers, and our social media is growing a little bit. We try to put some educational stuff on there, but yeah, it's all different ways.
That's a great icebreaker, though.
It is, because when Ashley was on, we were talking about it, it kind of started like during COVID. And I made a joke saying like, oh, what does overdose have to do with hunger? But the two are actually really related, right? Mm-hmm. Oftentimes, drug use is going to be another symptom of homelessness or being
Poverty.
unhoused, poverty,
Mm-hmm.
that whole social economic standing in life. So if you're giving someone the cover of not having the stigma of getting free Narcan, oh, I'm just there to pick up my macaroni and cheese, or
Yeah.
I was hungry and I was getting a hot dog at the stand. Oh, by the way, I also got some Narcan
Mm-hmm.
for myself, for my loved one, for my son, my daughter,
Yeah.
my best friend, right? So I think that was an amazing job. We talked about it like last year. You guys gave out over 20,000 naloxone kits
Yeah.
in 2024.
And we received over 200 reports of lives saved
Which is
through the
fantastic.
work that we did, which, like, you know, getting reports is like an amazing thing. Like, we know that there was probably a lot more than that.
Yeah. Oh, absolutely. Yeah.
Hey, John.
Yeah.
You've got 2 online questions.
Oh, I'm sorry. I'm not even paying attention to those.
Love that.
If
Love
you
the
want
live
to bring them up, or
Q&A.
I can bring them up.
I'll bring them up. I'm so not used to doing it. All right. So, what role can EMS play in bridging someone from overdose reversal to treatment, like buprenorphine or Suboxone?
So there's a lot of different programs out there. So there's the simplest program that exists is the EMS naloxone leave behind program. So being able to give someone a kit with naloxone and print materials that often include links to resources like us or medication assisted treatment providers, things like that. That's a very, like, you're handing someone something that they can then take action with later if they choose to. That's a very, like, what we see as like a lower barrier lift for EMS. The other programs are a little bit more structured and they require more resources and buy-in. But there's programs that do post-overdose follow-up that involve EMS. So in Cleveland, actually, they do a program where they're working on developing something for in-person follow-up, but they've been like calling people who've experienced an overdose to offer resources. And that has like grown in success. At first, you know, it took some time to build trust with people. And then there's a lot of programs that will do, like, they'll go out to people's homes or visit people when they're in the emergency department and provide those resources. But I think it's not saying, oh, do you want to get into treatment today? That's like the first thing with folks. You can offer that as a host of options because maybe that is something that somebody wants. But if you're only focused on how to get someone in treatment or someone sober or what have you, like, they'll probably stop listening. They might stop listening to you. It's showing that you care, first off. How can I help you? Is there basic needs? Do you have some place to stay tonight? Is there someone I can call for you? That type of thing. And then there's also programs that are being developed that I think it might be called like the Bridge program or something, where they actually do like Suboxone in the field. Like they equip EMS professionals to do so. I don't know how the prescriptions work. I don't know, but they are able to offer like MAT, like directly to folks.
So kind of like the naloxone leave behind program, we can have buprenorphine leave behind
Yeah,
programs.
something like that.
So the laws changed 3 or 4 years ago, where you had to have special training to prescribe Suboxone buprenorphine. Those went away, so now anyone with a DEA license that can write narcotics can now write for buprenorphine
Yeah.
without any additional training. So most ERs, and I know UH had a big program for that, but most ER doctors have been trained in how to prescribe buprenorphine, bridge them in the ER.
Yeah.
If we're doing that, we have to provide a 3-day prescription and then give
Like a
referrals
follow-up,
to follow
yeah.
up. Because we're not going to see them long term in the emergency
Yeah.
department, but we're going to refer them to resources in the community. That here you go here, they're going to start you on MAT program, but we'll start you here in the emergency department.
Yeah.
We'll actually microdose you up to your starting dose, give you 3 days, and then send you on your way.
Which I know sometimes can be a challenge, though, depending on like the potency that and
Well-
the like. I don't know what I'm trying to say, like their tolerance level, what they were already using.
Yeah, and they already have to be in withdrawal, because if
Yeah.
I give them buprenorphine, I'm going to precipitate
Put them
that
into withdrawal,
and it's
yeah.
going to be- Because now I have a blocker and an agonist
Yeah.
on board. I can't. I have to have you be within withdrawal before I can give you buprenorphine to take away the withdrawal symptoms and make you feel.
So regardless, it's not a comfy process
It's not. No, not at
for
all.
folks, but yeah. It's good to have that option. Like the easier we can make it for people, even though it is a just like not comfortable process.
Yeah.
John?
Yep. Yeah.
So you discussed trends before, and been in the city for a long time. We did see spikes of overdoses with Narcan usage. Probably, I would feel like the spike was maybe 3 to 4 years ago, and we've seen a downward trend. For you guys as a panel, where do you see? It seems like that's kind of, at least in this area, we have seen a slightly downward trend. I'd like to think it's a lot of the efforts like this that are going on, but is it also prescribing safety? Like, where do you guys see that coming from? The downward trend of having to use, like Narcan utilization in EMS seems like it's gone down over the last 3 to 4 years compared to its peak, probably right around COVID or right after COVID.
You guys want to answer or me to answer?
I figured it's gonna be a two-part
I've
answer.
looked into this. I've looked into this a lot. Well, because our whole goal is to make that happen, right? Is to see overdoses decrease, or at least like overdose fatalities, and yeah, overall reducing the risk. There's a lot of contributing factors, especially because this is a trend that we're seeing nationwide. And so when that happens drastically, it's like, okay, I wish I could say it's because we're out on the street corner distributing Narcan in Cleveland, but we're seeing it more than just in Cleveland, right? So what all is happening that's contributing to this? Nationally, I do think that there was a considerable effort to get naloxone out there. So I think that that has contributed to things. And this is not just what I think. I've read like a lot of articles on it as well. There has been a shift in what the cartels are doing. I don't know the ins and outs of it, obviously, but something happened with disruption and one of like the largest cartels, and deciding not to traffic as much fentanyl, which, you know, they can decide that, yeah, like yesterday, tomorrow they could decide something else, and where would we be at? We don't really know. That's the struggle with that being out of our control, but that was likely probably the most significant factor. There's some morbid thoughts to this of, did we lose such a significant amount of people that the people who are still here are the ones who have learned how to protect themselves and practice harm reduction.
Survivor bias.
Yeah. So I think that's a big factor, and people have learned how to prevent overdose. So there's a lot of things. I don't know if you have anything to add to that, but that's what I would say.
I agree.
Yeah.
The stats you guys, for you getting the Narcan out there, at least in this area, is amazing. To have the reports of the saves
Yeah.
on top of it is just validating, not only to you guys, but the program you're running. And to see it out there is a huge thing.
Thank you.
We have the Dawn kits as well, but to get out there into the people is a really good thing.
Thank you.
Yeah, I think naloxone's done a lot of the work, but we talked about this before we even started, that we're seeing a shift from opioid overdoses to stimulant overdoses. And is that now just because there's a difference in supply that's out there, and our stimulants may be easier to get hands on, and people are switching to that, and or their opioid is getting mixed with other stuff causing overdoses that we don't have reversal agents for.
So there's a couple of things happening. The opioids there's some evidence to suggest, at least locally, I'm going to talk locally right now because when it comes to drug supply, I only really know about Cuyahoga County. The opioids, there's some evidence to suggest that they're becoming less potent because they're mixed with tranquilizers like xylazine and another one called medetomidine. And though I'm glad that you brought up like naloxone can't reverse a tranquilizer overdose, they are not really leading to the overdose. The overdose actually is still being caused by largely fentanyl. So naloxone still works on the fentanyl, and just CPR, rescue breathing, all that is just even more important though, because people aren't waking up as quickly because they have such a heavy sedative in their system. But this year, actually the trend, what the medical examiner is projecting is a downward trend in opioid overdoses, lower than what we've seen, I think, in the last like 10 years. I don't quote me on that exactly, but we're projected to see double the amount of cocaine-related overdoses as opioids for the first time ever. First time in 20 years that cocaine-related overdoses have been higher than opioid-related overdoses, and at a record high. And that's the projection for 2025. And so that, I actually sent like a message in, like, I'm in this group thread with people doing this work across the country, and I'm like, are y'all seeing this in your areas? Like, is this unique? Seems to be pretty unique so far, but like trends move, so we'll see with time. What could be contributing to this is that cocaine is more pure now than it used to be. So all of a sudden we're seeing maybe more purity in cocaine, and so people who have been using cocaine for the last several years have gotten not very good cocaine, and so they've been using higher amounts, and now all of a sudden it's pure, and we're seeing a spike in cocaine-related fatalities. But those are complicated and different than an opioid overdose. Often we like to refer to as like overamping, because there's like a whole host of symptoms that are a little bit different than what we think about with a opioid overdose. Definitely looking into it a lot more and seeing what we can do to provide education. I just applied for a grant this morning actually to do work specifically in that area.
So treatment's very different for EMS too. If it's opioid overdose, so we talked about this during the podcast, is we're going to first focus on rescue breathing. Essentially, we're going to support their respirations, and then we're going to give them Narcan or naloxone to help reverse it. And our goal is not to get them up and awake and essentially feeling like hot garbage and vomiting.
Yeah, yeah.
Respirations.
Yeah, just to allow them enough to breathe them on their own and transfer them to the hospital.
Do you think any of this ties in whatsoever with the legalization state for marijuana? And now that it's easier to just purchase that?
I don't really think so. Especially, one thing I forgot to highlight is the demographic of people that we're losing. The biggest age and like racial demographic in Cuyahoga County is black men 55 and older. And also
Are you using them to opioids or cocaine?
cocaine.
Yeah, that's a population that shouldn't do cocaine.
And so we think about cardiovascular, things like that. And actually, when we talk about the trend that we're seeing nationally of a decrease in overdose deaths, in the black community, we're seeing an increase. So that suggests that maybe some of the stuff we're seeing locally with stimulants, potentially could be seen nationwide. So we need to make sure that communities that have already been under-resourced and underserved aren't missed in this conversation and missed in efforts going forward now that we're like, yay, overdoses are going down, which is an awesome thing, but not missing that. So, but I think that's an interesting point. I think, you mentioned maybe you're seeing more like young people trying marijuana for the first time and stuff. We really don't engage around marijuana use that much when we're talking with folks.
What I see from marijuana use is I see people that are trying it for the first time, or they took way too much.
Yeah.
Those are the people we see in the emergency department. Yeah. I'm not personally seeing cocaine overdoses in where I practice, but I'm in Portage County, which is farther away from there, so maybe not.
I just, personally, I feel like in our county, we're seeing more of the older population trying marijuana for
Yeah.
the first time, and they're calling us because they don't feel right. It's like,
Oh, it's the older population
Yeah.
too?
And
Yeah.
it's interesting, and that's why I was curious if you saw any trend in correspondence with that.
Not from what we've seen, but I do know that it's very potent. You can get very potent supply of that.
So one of the questions we got online, I think we just essentially answered, is if opiate overdoses are down, what will take the place? And I think that we talked about that. The stimulants, the sedatives are taking the place, and we're seeing an increase in cocaine, which we don't treat with naloxone, which not going to cause any harm, but it's not going to do any benefit.
And that's why we take the approach of harm reduction, because we have seen over 50 years of us trying to stamp out a drug, something always pops up in its place, and often it is more potent. We're in this period right now where we're seeing along the opioid side of things, there hasn't been a more potent thing pop up, so we're lucky right now. But usually once one thing gets scheduled by the government and criminalized, we had pills, those got more regulated, criminalized. Then we had heroin, that went away because it was addressed more heavily, and then fentanyl came in. So it's just, they call it opioid whack-a-mole, is what the philosophers call it. When we look at this.
Another online question, what's the biggest myth about harm reduction you wish more people understood?
There's so many. That it doesn't make things worse.
I'd say it makes things better, right?
Yeah.
There are programs worldwide. We have safe use spaces in Canada and Portugal.
And in the U.S.
And was there in
New York and Rhode Island.
Okay.
Yeah.
that those programs actually have shown to have a reduction in harm by creating a safe space, have increased people going into treatment. So I think that there's other things out there that we could be putting our efforts and energy into.
Yeah.
But anything other things that you guys want people to know about harm reduction?
That it isn't just Narcan.
Fair.
We see a lot of places and people who if that is how you start looking into harm reduction, I am all for it. That's amazing. But we see a lot of places that will use the term harm reduction or get funding to do harm reduction work, and all they're doing is giving out Narcan, but they are still against, actively against, or not promoting the whole piece of it, you know, the whole
Education
yeah,
side.
educational side of it, and shaming and coercing people and telling them that they, you know, they have to move in a certain direction rather than meeting people where they're at.
So I think we talked about this too. How might technology like apps, hotlines change the landscape of harm reduction? And I think this person probably watched our episode. We talked about the Never Use Alone hotline, which I think is a great resource that I didn't even know existed until I started doing prep work for this podcast. Anyone in the room know about the Never Use Alone hotline? So it's a number that a user can call. They'll collect basic information from you, where you're at, your name, and then they'll stay on the phone or on a device with you while you use, and they'll check in with you about every 30 seconds to make sure you're still conscious. And if you stop responding, they then call local EMS and say, hey, I've got an unresponsive person here at this address, and they were using, and then they dispatch you guys to go save their life, essentially. So I think Lish said that about 70% of people use alone.
It was like 70% of fatal overdoses for people
Overdoses.
that they were using alone.
Yeah, so that shows where like the gap really is. And so in addition to, so there's Never Use Alone, there's also another similar hotline. It's basically the same, called Safe Spot, that we give out educational materials onto. There's the SOAR initiative, SOAR. We actually, one of our team members, Jess, is a part of this group as well. They're a nonprofit. They do a deadly batch alert system. So you can sign up in your area to be a part of that and get text messages on if someone like tests cocaine and it has fentanyl, they can submit a report. And then it lets everybody know, hey, in this area, there's cocaine that has fentanyl. So there's that. There's, we have in our office what we call Brave sensor. It's through a company called Brave, where it senses if someone is not responsive in the bathroom. So if somebody were to go in there and overdose, we would get an alert on our phone. It senses like micro movements and breath. So there is a lot of cool technology in this, and we've talked with local like shelters and outreach centers about getting those in their areas, in their bathrooms.
That's a great idea, actually.
Any other
where
questions?
where do you see?
I have so many.
I know. We kind of hit on this off camera a little while ago. So without going into a giant rabbit hole,
Oh boy.
on the state or even on the national level, do you see that maybe politically, are things going your way? Are they not going your way? Are laws being written to help you, or the reverse?
I would say it is the reverse. So again, yeah, not to dive overly deep into it. At first, we just faced, I was actually on a cruise in January when the funding freezes happened, and then it was a freeze and then an unfreeze. And we faced a bunch of funding delays, which delayed programming, which delays life-saving programming. And so that was incredibly stressful. Things did end up moving forward. We're grateful for that, but we don't really know what down the road, like downstream effects that really had. And then what happened most recently is there was an executive order that specifically called out harm reduction as basically enabling people and not a part of the solution to drug use and homelessness. And so that is going to make our jobs harder. We've seen already that even though our funding streams from the federal government, we get 80% of our funding from the federal government. All of that naloxone comes from our Ohio Department of Health, and that comes through their integrated harm reduction grant. And so if harm reduction is a negative term, it's really challenging. And even some of our recent funding opportunities, they've lessened their focus on harm reduction. Like, they had harm reduction as a priority of these are the strategies we want to see happen. And now they're saying they've taken it out of the priority and said, well, you can only do activities if they're in alignment with the federal government. So, and most of the stuff that they focused on is just the Narcan and testing strips.
So this didn't affect AA at all? This didn't affect an organization like AA at all? This was strictly for...
No.
Well, I'll use that as a great segue
Oh,
to the
boy.
stigma.
Yeah.
Stigma.
Well, because, I mean, there's a lot of people that consume alcohol. We don't view them negatively
Right.
because they go out and have a drink after their shift. But
Or several.
or several, or are functioning alcoholics, versus the stigma that's associated with someone that goes home and uses methamphetamine, uses fentanyl, uses heroin, uses some other non-prescribed controlled substance, but still has a job, still returns to work the next day.
Which is most of the people who are using drugs, by the way.
Agreed.
Yeah.
So there's that big divide of stigma of, well, alcohol is okay because it's legal. Maybe the needle's moving for marijuana because in the state of Ohio, recreationally, it's more legal. That hasn't moved for other substances,
Yeah.
heroin, fentanyl, cocaine. Although cocaine's a Schedule II drug, so
No, I agree, and that was one of the biggest talking points, like I had mentioned before, was the stigma that I'd never considered. And even how we can change our verbiage in the back of an ambulance or at a patient's bedside to help in their further treatment instead of labeling somebody. It's
so we don't want to use the term addict.
right.
That's a
Right.
bad word to use. I just use patient whenever I'm interacting with
Yeah.
somebody. Call them by their name because they are a person. Use person first language for them. Other words we don't want to use are like user or drug abuser. I don't think any of us are calling them junkies.
I feel like that's antiquated.
A little bit, maybe we've come a little bit past that, but at the same time, we probably call our chronically drunk people either alcoholics or drunks,
Right.
and not necessarily that those people are experiencing alcohol substance use disorder as opposed to like opioid substance use disorder or cocaine.
Or they may have just had I guess if it's chronic, that's one thing, but like people get labeled as having a disorder even if it's something that they do recreationally or occasionally or something like that. And so yeah, when you use those terms, anytime we use a label like that, it is our brain's way of just being like, we're just going to categorize people in this and simplify things for ourselves to say everybody fits into this box. And when you do that to individuals, you just miss so much, and it makes it reduces your ability to provide quality care because you're not looking at the whole person, the unique person that is in front of you. You're putting them in that box.
And my experience with people that have a history of substance use disorder, if they're in recovery, they're very honest about that, and they're honest whether or not they had a slip up and they used recently, or no, I've been sober for 8, or I've been in recovery, I haven't used in 8 years. I'm going to believe them because okay, I know that that's in your past. That's not what's happening today. Let's talk about other things.
Yeah.
Most people that have substance use disorder and are in recovery, very open and honest about it.
Yeah. At least like we hope with like medical professionals. One thing that I know you talked about was like stigma between people who use drugs. Well, when people get into recovery, sometimes that carries through. And if someone practices abstinence-based recovery and someone doesn't practice abstinence-based recovery, or someone uses again, we just recently had someone who we knew that they were terrified to go back to their recovery community, and that's who you should feel the most comfortable going back to, you know? So it really carries through, but it's more than, I don't really want to, like, in my mind, there's really not blame on people in recovery and the community of people who use drugs. It's an entire society and how we've chosen to address this. And that's just the trickle-down effect. Like, until we all kind of start moving the needle on this, it's going to continue to impact people at every level.
You guys have any questions?
As he jumps in, I think that, no, I forget.
Mad dog.
Okay. So I think one of the challenges with EMS that makes us a little different than some other medical providers is we have a very short time frame with patients.
Yeah.
And so I think a lot of EMS providers probably have a little bit of a distance between themselves and the patients they treat. And so there tends to be a little bit of pigeonholing sometimes with it. Without getting into specific patients or anything like that, are there any kind of techniques that you guys could talk about or give us? I know we kind of touched upon a little bit, but to, I guess, maybe more humanize our patients that are using drugs or having drug issues or even overdose, to kind of, just as a quick walk away for us to try and not relate, but at least humanize them more, so we're not just pigeonholing those patients.
Such a good question, and I feel like where I struggle with finding a good answer is, like, I don't know what that looks like for y'all when you're out there, you know? And I know that every time I've seen a first responder, first thing you ask is, how are you doing today? Obviously, unless it's a very obvious situation that you don't need to ask that. And so I think that question, y'all probably already do this, introducing yourselves. I know that it's always asking about what the situation was, but maybe just like saying, like, I'm here to help you with this situation right now, but I also care about you, and if there's anything else I can do outside of this interaction, like, let me know. That could be something simple. Of course, you're with limited capacity, so that's why we want to be able to provide resources to y'all that you can have something to hand somebody, because you don't want those to also be empty words. Like, you want to have a phone number or something to give to somebody, but maybe making that statement and then knowing that you do have something could make a difference, even if you don't have the capacity to address everybody's needs in the moment. You know, it could be as simple as that.
That's a great point, though, that if I offer my help to you, I better have the resources to give you when you take me up on it, because how often does that happen?
Yeah.
And maybe that's the reason they're not asking for the help, is because it has happened, and somebody offered them, oh, I'll be there. Were they?
Yeah.
So I could get that.
There's definitely a soft skill in emergency medicine and EMS that, and I talked about this in our podcasts, like, you have a very condensed time. You've got maybe 5 minutes with that person to convince them that I'm trustworthy, you can trust me, I'm here to help you, and not to push me away. And I think that maybe having that, hi, I'm John, I'm a paramedic, I'm going to help you. What's going on today?
Yeah.
Oh, you need some help? Here's some resources, whether it's primary care doctor's office, MAT, drug assistance, even, hey, is food a problem for you? Here's our local food bank that can help with food. Like, I think that in medicine we want to focus on just the medical things that are wrong and ignore the social aspects, whether that's housing, food, good health care, a support system, and realizing what you guys have in your own community of who you can then refer them to. Like, hey, I'm going to be here for this next 10-minute ride to the hospital. We'll hand you off. They'll take great care of you. If you need something afterwards, here's a list of people to call for what you're kind of looking for. Like, if you need food, this is what you need. If you need a doctor, you just need someone to talk to, here's the right phone number for you to reach out to and talk to.
And knowing the limits of your community too, and knowing when to say, like, I'm sorry, I wish I could offer more. Because, like, we see that when it comes to housing. Like, there's not a lot of resources, and if people often don't want to go to some of our shelters, and for like a lot of good reasons, safety, their belongings, like all sorts of things. And so, I've had to sit with people multiple times and say, I'm sorry, this sucks. I wish there was better options.
The shelter program in Northeast Ohio was actually hit very hard by all the cuts that happened this year as well. And I don't know if we've recovered from those, but
Yeah.
so I think this goes along with your question too. Is what can EMS crews do differently on overdose calls to reduce harm beyond just Narcan administration? So offering those resources, I think, is great. Give them their number. Hey, I know these great ladies from Thrive for Change. They'll be happy to help you out. And a lot of what they do is just it's not just the opioid stuff, right? It's not just Narcan, it's not fentanyl testers, it's not exchange. You guys have tie-ins to primary care, MAT, and other services. That
Provide
you guys
clothing. We have like random stuff that we get that's like blood glucose monitors. Like we give out all sorts of things, and so we really try to just, if someone is sent to us that is experiencing homelessness or mental health challenges or anything related to drug use, like we will, even if it's none of those things, like someone walks in our door, we try to help them with what they need. And I was thinking of something else, but now I forget. Oh, so you all mentioned earlier, I think, like your approach to overdose response with naloxone and focusing on the rescue breathing and the oxygen first, and not wanting to overload someone with naloxone unnecessarily, essentially. Is that a newer shift for y'all, or has that been consistent?
It's been probably consistent from our education. The problem becomes is when I call 911 and I say I have someone who's unresponsive and I think they might have overdosed. Despite their best efforts, they're sitting at the fire station. They're going to have to hop in their vehicle and go to that call.
How long it's been and all of that.
Well, it's going to take them a few minutes to leave the station, get in their ambulance, turn on the woo-woos, and drive to the house. Meanwhile, you've got police that are on patrol in their cars already. They might be 30 seconds from that call. They're also going to get dispatched to that call. And you get that first responder and a police officer that their only tool in their tool bag to reach for is going to be Narcan. So if they've got
They don't do CPR.
they don't do rescue breaths. No, they'll do CPR. They'll do hands-only CPR if they're in cardiac arrest. They don't have the ability to bag and they're not going to bag a patient. So their only option, their only thing in their tool bag is Narcan. So they'll give 1 4 milligram intranasal naloxone and it didn't work. I've got another thing of Narcan in my bag here. I'm going to give them the other nostril. Someone else is going to show up. Hey, you got more Narcan because this hasn't worked. So oftentimes what happens, the first people on the scene, their only tool they have is naloxone. So they will get 4, 8, 12,
I didn't know that they couldn't do
milligrams.
full CPR.
They're not trained. If they come upon a patient who's in cardiac arrest, they will start hands-only CPR. They will not do rescue breaths, to the best of my knowledge.
I've seen it. It's rare, but one time I actually had you might have been with me. we had a cop that was doing mouth-to-mouth, and the patient woke up from the Narcan, and he ate whatever the patient was eating. So then, of course, they talk, and then they never do it again. So they're not trained with BVMs. They don't carry mass barrier. Some of them do, but yeah, I agree with Doc. That's generally what you run into.
Yeah, because we've seen another trend that thankfully I think in Northeast Ohio, like people have, through us and other groups, like gotten the education out there, a trend to try to move towards higher dose naloxone and even other medications that aren't even naloxone, that it's called Obvi, that have like a much longer half-life, because there's this thought process that people need so many doses, and we're like, well, as long as you're administering and doing, whether it's rescue breaths or CPR, depending on the needs in the situation, like you should be able to allow time in between doses and to give someone at the level that they need.
The one thing we don't want to do is wake them up to the point where they can sign off. I think it's much safer that we would transport somebody so they can be monitored for a bit. So, like Doc said, we kind of stress that we're restoring respirations, and if we woke them up and they're fighting us, and now we have to sedate you again, that's kind of contraindicated.
Yeah, or overly sick
Yeah.
and all of that. So it's interesting that is probably a big contributing factor.
Well, I think we got really good at giving that tool to all of the law enforcement officers, that they all have Narcan on.
Yeah, which
Because
that
before
is a
they were
big
just-
plus. That
they
is
were just
amazing.
standing around
Not
and
denying
not doing
that.
anything. So
Yeah.
I think that's where one of the switches is coming from. From our training, I think it's always been airway first. A bag valve mask and breathing for our patients is financially cheaper for us than actually administering Narcan. If we're talking about cost benefit, not best for the patient. We want to give them naloxone. We want to wake them up a little bit, just enough so they can breathe on their own, metabolize that drug. They need observed, because if they stop breathing again,
Yeah.
we can breathe for them again, and we know that they're going to need more naloxone. And that's because the opioid drugs that they use, the half-life for that drug is longer than the antidote that we have, so we want to watch them for hours. Fentanyl's
Yeah.
a pretty short half-life, unfortunately, if it's fentanyl, but if you're talking about oxycodone,
Yeah.
if it's an oxycodone overdose, that's 6-hour half-life right there.
Yeah. But that's interesting, and I'm just glad that there's been a lot of efforts to try to further like the education on what's just been kind of coined as like compassionate overdose response, rather than just like the back-to-back or needing something that lasts like 12 hours and puts someone in precipitated withdrawal for that
Yeah.
long. Yeah.
All right, you got a few more questions here
Okay.
before we finish up. How would you measure the success of a harm reduction program? Lives saved, decrease in ER visits, engagement in treatment programs? I mean, right now you guys are engaging right now in lives saved, which is a fantastic number.
Yeah.
You're seeing a decrease in opioid use. Not exactly sure why, but how else would you consider a success?
We track a lot of different information, but I could spew a lot of like data, like obviously those like impact numbers and the number of people coming to our program. We know that research shows that the likelihood to engage in treatment is much higher, and we see that happen by the number of people we're able to link to care, which I don't have the stat off of the top of my head, but I can share an impact story of someone that we met. It's almost probably a year and a half ago now. When we met him, he was living outside and using meth and fentanyl. And he overdosed probably 15 times in the time that 6 months that we engaged with him doing street outreach. And none of those times, like 911 was called. So if you think about like all the times that we miss how many overdoses are actually happening in the community. Thankfully, he was okay. We encourage everybody to call 911, but sometimes people don't. And especially when you're living outside and in active use, there's a lot of fear around different engagement with institutions. So we started engaging with him, providing safer use kits, safer smoking kits, sterile syringes, and food, basic needs items. And he started coming to our weekly service hours. He would volunteer some, all while like in active use. We provided him clothing as well, and just developed a good relationship with him. And then one day, like after 6 months, I got a call on our work line from a lady, was on the other line, and she was like, I have this man here, and he said he needs help. He has to use my phone to call you all. that's the thing, is our number is on all the materials in every single like safe use kit that we give out. Everything has our information, so people really learn that, and we text with our participants, you know, they reach out for help, all of that. So it really creates that relationship development. And so he gets on the line and he's crying and he's like, I don't want to do this anymore and I want to go to treatment. And so when that happens, especially with someone who is so high risk and he's reaching out, that's what he wants for himself. No one was coercing him to do that. We drop everything. My staff went and picked him up, brought him back to the office. We called, we did an intake for him at New Day Recovery, which is one of our places we refer a lot of folks to. They're very accepting all pathways to recovery. All of their staff, we've trained them on harm reduction. They're out in Niles and they have a beautiful like new center. Makes people really feel at home. And called them, did their intake with them. That takes like 25, 30 minutes. And then got him clothes from our clothing closet, and my staff actually took him an hour basically away to treatment. And he, you know, with recovery, everything ebbs and flows, like every day is a different day. But as far as I know, because like he's kind of been able to develop his own like recovery community, so he's less coming to us now, but it's been over a year and you know I haven't seen him out on the street. He's in recovery.
Success.
Yeah, so if you think about like how high risk to now, and that would not have been possible. He had a horrible experience, like abusive experience at a previous treatment center, and so his likelihood to go to another one was so low. But through engaging with our staff, our peers out there with the harm reduction supplies, that shows that like you're saying, and for y'all, it's like if you were to offer like a syringe exchange program, I feel like that would blow some people's minds. Like, oh, like you're like up on stuff and also like cool with like I can trust you to talk about my situation I'm in right now. Like you're not asking me to be someone that I'm not in this moment, and you care about me as I am. So I think that that is what really makes the difference, and so it's those stories behind the numbers, you know.
I think you hit on the fact that developing a relationship with some of these patients is kind of what gets you to the end goal of recovery. And so in EMS, there's a new move to what we call community paramedicine.
Mm-hmm.
We've started up some community paramedicine programs. And what that is a paramedic or a nurse that's on EMS staff that reaches out to the high utilizers to help reduce their call volume. So if you had a high utilizer of those services, if you build that relationship with them, you're actually going to reduce your call. EMS will reduce their call volume. Mm-hmm. You're reducing their risk to go to the hospital, to overdose, and then finally, when they were able to and ready on their own terms to go into treatment and get themselves into recovery, you were there. They were the call, right?
Yeah. And I do want to. Oh, you're going to say something?
I kind of, if you don't mind, I just kind of want to add our open service hours from 2 to 6 every Thursday are really, really valuable to the community. But I feel like it's valuable to me too because when it's like weather pending, sometimes we're like inside, and when they come in, I'm like one of the first people they see. And one of the first things I say is, we are so happy to see you. And if they're using substances, if they're not using substances, if they went to treatment and they started using substances again, they know that they can walk through our door and we're not going to judge them. And I think that's really valuable. Some people don't have friends, they don't have family, they have us. And I feel like a lot of people feel like recovery is the end goal, and if it is, that's great, but people have to be ready on their own to go to recovery, and we don't push that on them. And I think that's where like a lot of stigma comes from, and that's where a lot of people kind of like get lost in like, this is who Thrive for Change really is. We meet people where they're at, and everybody else can do whatever they want to do, which is great, but we're really excited when people come back over and over and over again, no matter what, because they're still here.
Yeah, I'm glad that you said that because that's what I was going to say. Like you mentioned, like the end goal being recovery, but ultimately, our end goal is whatever their end goal is. You know.
I see recovery not necessarily meaning abstinence.
Right.
But
Which whatever positive change, which I think is good. But I think it's also important to clarify that because so many people haven't learned that is what recovery can mean, unfortunately.
Right.
We have made recovery so synonymous with like sobriety and abstinence. But I know that like that is what you were meaning, but I think that, a lot of folks still are learning that, you know? And so it's important, but I think that's very true. People always come back to us and we take care of people's cats. We do all sorts of stuff. Like, it's a wild day, always.
Any other questions in the room before I get the last online question? All right. If you could give one message to EMS providers about harm reduction, what would it be? It could be two. We don't have to limit it.
Yeah. I would say that we want to work more with y'all from the like strictly harm reduction focused, like that's all we do kind of lens. Like we want to work more with y'all because sometimes I feel like there's so many like opportunities that like if there was a peer there or if there was like someone who had the resources there, something different could happen for folks. And so like we want to be able to build the knowledge and like resources out there for those like key touch points to be able to be as impactful as possible for people. So I think that's pretty much it. Would be the main one. Yeah.
Anything else coming up this week you guys want to talk about?
Thank you. Yes. So Sunday, August 31st, this upcoming Sunday is Overdose Awareness Day, and we are actually doing an Overdose Awareness Weekend initiative this year. Typically, Overdose Awareness Day events are focused fully on honoring loved ones, which is super important and meaningful, and that is a part of what the day is about. And it typically brings together folks for a memorial and sharing of resources. And those events, there's a couple of those still going on around Northeast Ohio. Project Noel is doing a really great event. I'm gonna forget exactly where it's at. It's somewhere on the east side. I can send it to you. They always do an incredible like memorial and coming together to spread awareness event. What we are doing this year is trying to get overdose awareness into spaces and in front of people who aren't thinking about it this weekend. So we have coordinated an initiative to mobilize Greater Cleveland to address the overdose crisis by setting up at different music venues throughout Cleveland and going out into public spaces and distributing naloxone. So we're going to be at Edgewater Beach and going to go down to like the Flats area. The air show is going to be going on, so there's going to be a lot of people out and about. And so we have wagons that we take with Narcan in them. Those are a huge hit. They do so well. We have at recent like events and festivals, we've distributed double the amount of naloxone. By taking those out, we wear shirts that say "Ask me for free Narcan." All of our wagons have signs that say on it, and we have people running up to us. And so we're going to be, our goal is to distribute 1,000 naloxone kits, train 500 people in Greater Cleveland on how to recognize and respond to an overdose, and hopefully build more engagement on this issue that can then be kind of build momentum for the coming months. So bringing people in to volunteer, get involved, start conversations with their families, reach out to us for resources. And we also have several businesses we're partnering with for fundraisers. There's a cycle studio that's doing a benefit class for us, a yoga class. So if, I know I'm gonna share the site with you, but if you go to thrive4change.org/awareness, you'll find the webpage that talks about the initiative, and people can volunteer and get involved, so, or donate.
Yeah, go ahead.
Also,
Yeah.
I am the volunteer coordinator, so if anybody ever wants to come by on a Friday, such as this Friday, Russell Kit Building from 12 to 4:30.
Yeah, we put together all of our harm reduction and Narcan kits that we give out, and we couldn't do it without volunteer help.
Sure. So I'll do that to plug our website, prehospitalparadigm.com. What I'll do is I'll post all of their stuff up for the weekend on our homepage, so it's right there available to everyone. We've got our show notes on there. We've got information about our blood drives. We have a blood drive coming up at the Mahoney County Fair in Canfield this weekend. We've got free continuing education for EMS that's available on there to get signed up, information about mental health, and also a way to ask us a question here on the podcast when we're not live. Our website for the education site is education.prehospitalparadigm.com, but you can just go to prehospitalparadigm.com for all that information. Again, I'd like to thank Highland Heights for having us here, taking up your Monday afternoon. Tones didn't drop. And then I'd also like to thank First Net and Cradle Point for sponsoring us. Thank you for coming out and talking, and thank you everyone, and have a good night.
Thanks so much for
you.
having us. Good night. We're not live anymore.